We are back with another series. Let's revise PYQs. This will benefit you in your upcoming exam. Let's look at the first question from this video. Question 1. Identify the marked region in the given spirometry. Your options are, and the correct answer is functional residual capacity. Here's the explanation.
Lung capacities. Okay. So capacities are nothing but it is combination of multiple lung volumes, right? So all of you know that if you add up this tidal volume plus inspiratory reserve volume, this is known as inspiratory capacity of the lung, right? Simply you can add up 500 plus 2000 ml, that will be your inspiratory capacity. Then if you add up this tidal volume plus IRV plus expiratory reserve volume, combination of these three volumes is known as vital capacity or VC, right? If you combine only the residual volume plus your expiratory reserve volume, this is known as functional residual capacities. We have discussed this functional residual capacities multiple times. This is known as the resting lung volumes, resting capacities of the lung. That is nothing but RV plus ERV. And if you combine all these four lung volumes, right, for example, residual volume plus ERV plus TV plus IRV, that is nothing but known as total lung capacities.
Question
right?
2. Identify the correctly matched pair of substances with their renal clearance from the graph below. Your options are, and the correct answer is A. Glucose, B. Bicarbonate, C. Inulin, and D. PAH. Here's the explanation.
This is a curve. In this curve, in the x-axis, I am calculating the concentration of pH, and in y-axis, I am calculating the clearance of pH. Okay. So, whenever the concentration of pH in the plasma is low concentration means up to 10 milligram per dl. If your pH concentration in the plasma is below 10 milligram per dl, okay, so you have injected little amount of pH according to the protocol, your plasma concentration of pH is lesser than 10 milligram of dl. In these cases, if you measure the clearance of pH, that will be equal to 625 ml per minute. What is that? This is the exact renal plasma flow, effective renal plasma flow that you are measuring, right? So this 625 ml clearance will be present up to this 10 milligram per dl concentration. If your pH concentration is more than this, suppose you have injected huge amount of pH by mistake and your pH concentration is rising more and more and more and more, what will happen to the clearance of pH? The clearance of pH will decrease, and then it will be stabilized like that of inulin. Okay, I'll tell you what is this flat portion. But this flat portion indicates that this is the condition where secretion is almost stopped. It is only coming from the urinary amount is only coming from filtration. Okay, that is similar to like that of inulin. Inulin is only filtration. So whenever it become like that of inulin, then the curve will become flat. But look at, so this point is the T max point, transport maximum point of pH. What is the meaning of that? Means at this condition, there will be saturation of all the carrier protein, all the transporter protein which is secreting the pH at the level of PCT lumen. So whenever there is saturation of all the transporter, no further increment of secretion is possible, but your plasma concentration is rising. So your plasma concentration is rising, but increment of secretion is not possible. So what is going to happen to the clearance? The clearance is going to be reduced and then it will become flat. So this way, this curve is very, very important. Okay, if you inject huge amount of pH, whenever your pH concentration in the plasma is greater than 10 milligram per dl, in these cases, the clearance of PAH will give you a false low value of renal plasma flow. Okay, so if you want to measure the renal plasma flow by pH clearance, the concentration should be lesser than this 10 milligram per dl. Then and then only you are going to get this kind of curve, right? Okay. Now in this clearance curve, If I ask you how the clearance of inulin will look like, inulin. If I give huge amount of inulin injection, okay, what will happen? Inulin is a freely filtrable substances. More you inject, more will be the concentration, more will be the filtration. So in case of inulin, injection amount is not a problem, because in case of inulin, more you inject, more will be the concentration, so more will be the filtration, and proportionally more is the plasma concentration. So what will happen? The ratio will remain constant. So that way, the clearance curve of inulin is a flat line, is a simple straight line, okay, irrespective of the plasma concentration. Whenever your plasma concentration is rising, inulin clearance is not going to change. So this is clearance curve of inulin. Okay, so rather than C inulin, I should write this is the inulin curve, okay, because it is the curve of clearance only. So this is inulin, okay, and this is our pH. So if I ask you clearance of creatinine, where you want to put that curve? Clearance of creatinine, it is secreted. Secreted means the value will be more than inulin value. So the creatinine clearance curve will be just above the inulin clearance curve. So this is the creatinine clearance curve. If I ask you clearance curve of glucose, where it will be present? Clearance of glucose in non-diabetic person, how much I told you? 0, 0, 0. So up to a certain volume, up to a certain value of plasma glucose concentration, when it is non-diabetic, the clearance of glucose is 0. That's why it is in the same line with that of the x-axis. But if the person is diabetic person, in the diabetic person, if you measure the clearance of glucose, so clearance of glucose you are measuring in case of diabetic person. So there will be certain amount will be present in the urine and the plasma concentration. So in these cases, it is not 0, it is more than 0. So that's why more the plasma glucose concentration in diabetic person, more will be the clearance of glucose in diabetic person. So that way, in case of non-diabetic person, non-DM person, the clearance of glucose is 0. But in case of diabetic person, the clearance curve will be more and more rising towards the inulin curve. So this is the clearance curve of glucose, right?
Question 3. Which statement is accurate about the nerve action potential curve provided? Your options are, and the correct answer is point B to D is a refractory period. Here's the explanation.
Now if I want to note down the duration of depolarization phase of action potential, so what I will do, I'll just drop on perpendicular from this. So I'm dropping on perpendicular from here, okay, and in between these two, okay, if I measure the time duration, this is nothing but time duration of depolarization. This is nothing but depolarization phase time duration, right? So this is the depolarization time duration, and obviously starting from here, if I measure the time up to the end of this action potential, this is nothing but repolarization time. Fine. So depolarization time, repolarization time. Now, whenever we are talking about refractory period, okay, refractory period means that period where second action potential generation is not possible or maybe difficult. What do you mean by that? Suppose I am giving you a question like this, that this is one action potential, it has been generated due to a stimulation here. This is the point of stimulation. If I give another stimulation at this point, can I get a second action potential? Answer is no. If I give a second stimulus here, can I get a second action potential? Answer is no. If I give a second stimulus here, can I get? Answer is no. But if I give a second stimulus here, then I may get a second action potential at this region, right? So based on this concept, the concept of refractory period has been developed, right?
Question 4. What findings would be observed in a patient who has suffered a cervical spine injury due to a road traffic accident, whereby the fracture fragment has penetrated the lateral aspect of the dorsal column tract? Your options are, and the correct answer is, absence of ipsilateral arm proprioception. Here's the explanation.
Now this TEBS dorsal is TEBS means this is wasting, right? Wasting away, right? Destruction of the dorsal root or dorsal column fiber, right? Selective destruction of the dorsal root or dorsal column fiber. This is typically caused by neurosyphilis infection, right? And there will be loss of sensation of the position sense and vibration sense. Obviously, that is carried by the dorsal column pathway. There will be numbness and lightening pain towards this root, okay, because this root is damaged, so there will be lightening pain around this nerve fiber. There will be sensory ataxia also. The person will not be able to understand the proprioceptive input from the ground, so proprioceptive input from the joints, so that's why there will be ataxia, right? Drunken gait, right? Apart from that, the reflex will be diminished and weakness will be there, because the pathway for reflex that we have seen, the stretch reflex pathway and every pathway, they enter through this dorsal root only. So if the dorsal root is damaged, then this reflex pathway is also going to be damaged and there will be weakness of the muscle. So this is typical of Taves dorsalis.
Question 5. In your OPD, a child with loose stools for a day came to you. During examination, you observed signs of dehydration and provided the child with ORS. Through which receptors does ORS aid in glucose absorption? Your options are, and the correct answer is SGLT1. Here's the explanation.
If you think of glucose or if you think of galactose, right? Suppose this is the luminal side, so they are present at the level of lumen of the GIT. All of us know that the transporter for this glucose or galactose absorption, which are present at the level of lumen of the intestinal cell, that is the enterocyte, this is nothing but SGLT1, sodium glucose linked transporter. So it is going to absorb one molecule of sodium and one molecule of either glucose or galactose, right? If the glucose concentration is more, okay, then the glucose will be absorbed first, and if the galactose concentration is more than glucose, then the galactose will be taken up along with sodium.
Question 6. What mechanism is observed in the baroreceptor reflex among the options listed below? Your options are, and the correct answer is negative feedback. Here's the explanation.
If your blood pressure is decreased, what will happen? Which system is going to correct this sudden decrease in blood pressure? Obviously, the most rapid control system, that is the baroreceptor. So now this will activate or inhibit the baroreceptor. This is going to be inhibit the baroreceptor, because baroreceptor will be active in high blood pressure, not in the low blood pressure. So whenever your blood pressure is decreasing, the baroreceptor will be less active, or I am writing here, the baroreceptor is getting inactive. Now, just now we have discussed, if the baroreceptor is inactive, this is, okay, going to activate the vasomotor center indirectly, or you can say the vasomotor center or VMC will be activated because of the tonic nature, okay, because of the tonic nature of this center, right? So whenever your vasomotor center is active, we know that it is going to activate your sympathetic system, okay. Sympathetic system activation means it is going to increase the force of contractility. So what will happen? The force of contraction will be high. Force of contraction high means there will be increase in stroke volume, and this stroke volume is going to correct this fall of stroke volume and cardiac output. Not only that, sympathetic system is going to increase the heart rate of the person also. So the multiplication product of this heart rate and the stroke volume, okay, heart rate and stroke volume, they are going to increase the cardiac output. Not only that, the sympathetic system is also going to causes vasoconstriction. So if there is vasoconstriction, what will happen to the TPR or total peripheral resistance? It is going to be high. Increase TPR, total peripheral resistance, will be high. And vasoconstriction means there will be constriction of the arterial system also as well as venous system. So if you compress the vein, the extra blood which was pulled in the venous system, that will be pushed toward the heart. So what will happen? This is going to increase the venous return also. And by this all means that increase in contraction, right, increase in stroke volume, increase in heart rate, increase in venous return, by all this means the blood pressure which was decreased already, that blood pressure will be corrected soon.
Question 7. Prolactin level is highest during? Your options are, and the correct answer is 24 hours after delivery. Here's the explanation.
What are the factors which controlling this prolactin secretion? So this estrogen during pregnancy, this is the most potent stimulus for prolactin secretion.
Question 8. C-wave of JVP represents? Your options are. And the correct answer is tricuspid bulge into right atrium during isovolumetric ventricular contraction. Here's the explanation.
During the isovolumic contraction phase, because of ventricular strong contraction, the tricuspid valve is bulging towards the atrium cavity, although it will never open up towards the atrium cavity normally because the chordae tendineae are there which is attached with these valves. They will pull the valves, but there will be little bulging of the tricuspid valves towards the atrium cavity. So whenever the valve is bulging towards the atrium cavity is compromised. So what will happen to the cavity pressure? There will be little rise of cavity pressure in the right atrium, and that little rise of cavity pressure here is C-wave in JVP or C-wave in atrium pressure. So I can understand that C means this is C stands for cusp, and what is happening to the cusp? There is bulging of cusp. Okay.
Question 9. In a patient who experienced a stroke 2 days ago, the current symptoms include uncontrollable, forceful, and jerking motions of the limbs on one side. Where is the probable location of the lesion in this individual? Your options are. And the correct answer is subthalamic nuclei. Here's the explanation.
Direct pathway is stimulatory to thalamus, right? And indirect pathway is inhibitory to thalamus, right? Thalamus. Great. Okay. Now, what the dopamine from this substantia nigra is doing, dopamine is acting on D1 receptor here, it is acting on D2 receptor here. We all know that if the dopamine is acting on D1 receptor, then CMP level in the cell will be enhances and it will stimulate the direct pathway neuron. And D2 receptor means it is an inhibitory receptor. So the CMP level will be suppressed and it will inhibit the indirect pathway. So basically, dopamine is stimulating the direct pathway and inhibiting the indirect pathway. Means the ultimately dopamine is stimulating the stimulatory pathway and inhibiting the inhibitory pathway. So what will happen? Because of this dopamine, the thalamus will get excitation only through both the pathway. Getting my point? That's why we all know that dopamine is present normally in this basal ganglia loop, and this dopamine is enhancing the thalamus. Okay, it is giving positive feedback to thalamus. Even this negative movement is inhibited by this dopamine. So that's why all of you know that if there is distraction of this dopaminergic neuron, so what will happen? The thalamus will not be stimulated, not that much. Okay, stimulation will be less at the level of thalamus, and if the thalamus is stimulated less, then what will happen to the movement? Your movement will be slowed down, and that is the basis or bottom line of bradykinesia or akinesia, which developed in case of basal ganglia disorder or rigidity. Okay, rigidity. So all these symptoms are explained by this dopaminergic distraction when the inhibitory pathway will be dominant one. It will inhibit the suppression, and this is typical of Parkinsonism disease. Now, apart from all this, we also know that there will be tremor in case of Parkinsonism disease also.
Question 10. Identify the true statement regarding the segment marked in red on the myocardial action potential curve. Your options are. And the correct answer is plateau phase of the fast type action potential. Here's the explanation.
Plateau portion, this part is known as the phase number 2, and then one part of the action potential is returning back to resting membrane voltage. This is phase number 3, and resting membrane potential is known as phase number 4. So I can easily find out that in case of fast type action potential, there are 5 distinct phases. Okay, so I can easily understand that phases in case of fast type action potential is start from 0 to phase number 4. Means total 5 phases are there.
Question 11. Which of the following options has the slowest conduction velocity? Your options are. And the correct answer is postganglionic sympathetic fibers. Here's the explanation.
Look at the C fiber first. C fiber is also for pain and temperature, but here the temperature is warm temperature. Now, I can just understand that pain is carried by this A delta fiber also, and it is carried by the C fiber also, right? But A delta fiber, it is a kind of myelinated fiber, and C fiber is an unmyelinated fiber. So obviously the pain which is carried by this A delta fiber, the conduction velocity will be higher. So that's why the pain which is carried by this A delta fiber, this is known as fast pain, right? Fast pain. And the pain which is carried by the C fiber, this is known as the slow pain. The difference between this fast and slow pain will be discussed in detail in central nervous system chapter, right? So for the time being, you remember the fiber difference. Now in between, if you look at this B fiber, the B fiber is the autonomic fiber, that is the preganglionic autonomic fiber is the B fiber, and the postganglionic autonomic fiber, mainly the sympathetic, is the C fiber. Getting my point? So B fiber is the preganglionic autonomic fiber and C fiber is the postganglionic autonomic fiber. So you have to remember this classification as much as possible because multiple questions has been given from this classification system. So try to remember this classification as much as possible, whatever I am saying. So just you don't forget that this fast pain is carried by A delta fiber and the slow pain is carried by C fiber. Similarly, temperature, cold temperature is A delta and warm temperature is by C fiber. Now the next column here is the conduction velocity of the nerve fiber. Am I going to remember all of this conduction velocity? Answer, you may not. But at least remember that whenever you are moving from A fiber towards the C fiber, okay, because you are moving from myelinated towards unmyelinated, okay, and the diameter of the fiber is also decreasing from A towards C, the conduction velocity will also decrease.
Question 12. Which specific neurotransmitter is accountable for causing dilation of the small intestine in a forward direction? Your options are, and the correct answer is VIP, vasoactive intestinal peptide. Here's the explanation.
If you look at the neurons which are projecting towards the distal part of the GIT, they are going to secrete other neurotransmitter like, for example, vasoactive intestinal polypeptide, VIP, nitric oxide and adenosine triphosphate. In presence of this neurotransmitter, we all know that there will be relaxation of the smooth muscles of the GIT. That's why the distal part of the GIT ahead of this food particle is going to relax, and this is nothing but the peristalsis.
Question 13. The primary source of testosterone production is primarily contributed by. Your options are, and the correct answer is Leydig cells. Here's the explanation.
The testosterone is produced from the Leydig cell which are present outside this abdominal compartment.
Question 14. Following complete ileal and partial jejunal resection, the patient is most likely to develop. Your options are, and the correct answer is vitamin B12 deficiency. Here's the explanation.
Vitamin B12 or cobalamin, all of us know that the dominant absorption site of vitamin B12 is iron. So all this thing I have written here that carbohydrate, protein and lipid maximum absorption is duodenum, right? Similarly, iron and folic acid, they are also maximally absorbed at the level of duodenum, but bile acid as well as the vitamin B12 or cobalamin, they are maximally absorbed at the level of distal eye.
Don't forget to like and subscribe if you found the video interesting. See you